Okay, well, if you're ready, Jason, we'll get going. Welcome everyone to Grand Rounds, Wednesday, June 4th. Nice warm summer day. We'll begin with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The people of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. Today we have Dr. Jason Brophy presenting to us. He's a pediatric infectious disease specialist, and he's the medical director of the HIV clinic, an associate professor at the University of Ottawa. A little bit more background on Jason. He's a researcher here at CHEO, and his research interests are in pediatric and perinatal HIV, congenital CMV, and tropical zoonotic infections. He is the current chair of the Canadian Pediatric and Perinatal HIV/AIDS Research Group and co-lead of the Ontario Regional Team of the CHR Pan-Canadian Network of HIV and the STBBI Clinical Trials Research Network. He works part-time as a pediatric HIV clinical advisor for the Clinton Health Access Initiative. I hope to hear more about that, Jason, supporting pediatric HIV care optimization in West Central Africa and Southeast Asia. His areas of research would include congenital CMV, tropical zoonotic infections, and vaccines. And the title for his presentation is, as you see on the screen. I'll let him announce it. Over to you, Jason.
Thank you, Dara, and thanks everybody for tuning in and for giving me the chance to present on this topic that I'm very passionate about. We often hear from our patients in clinic that the hardest thing about living with HIV is stigma and people's misunderstanding or misperceptions about HIV. And I always say that a lot of us in healthcare are operating on dated information from when we were in training or from many years ago that's not up to date. And so rather than complain about it, I thought maybe I should update people and then it's on them. So I hope today to share with you what's new in HIV in 2025 and what do you need to know. So these are my disclosures. I have a little bit of industry interaction with Moderna previously as a site co-investigator for the Moderna vaccine trial for COVID. And I've done some work with ViiV Healthcare on an advisory board for pediatric ARV development, which I want to encourage. So my objectives for today are to review epidemiology globally and in Canada of HIV overall, pediatric, perinatal HIV in particular. For all of you to learn about the new treatments that are available for HIV treatment and prevention, and to understand that 9 people have been cured of HIV and how might that impact us. So these are my top 10 things I want you to know by the end, and so we'll see if I manage it by the end. So I'll start with the epidemiology part. So each year, UNAIDS, which is a WHO affiliated organization, releases at the AIDS conference the previous year's epidemiology. So we know from the end of 2023 that we're up to almost 40 million people living with HIV globally. This is the largest number ever, which sounds maybe disheartening in one way, but I see it as very heartening in that means that people are being diagnosed and surviving with HIV. In the past, our numbers stayed quite steady, and that was because new infections were keeping pace with deaths, and so that's not good. So in 2023, there were 1.3 million new infections and 630,000 deaths. And for children less than 15 years, it was estimated there are 1.4 million children living with HIV, 120,000 new infections, and 76,000 deaths. What does this look like over time? So you can see that the numbers of new infections per year on the left and of AIDS-related deaths per year on the right have both been steadily decreasing over time. So this is progress. You can see the little yellow dot. That's the goal. So we're we're making progress, but we're not meeting the goals. But still, progress is progress. Where are people living with HIV living? So the majority are still in Eastern and Southern Africa with almost 21 million. But you can see significant numbers in West and Central Africa at 5 million and Asia and the Pacific at 6.7 million. I've done a lot of work globally, and I've seen this man's picture on posters in clinics around the world. It dates back to the early 2000s, and it was taken by Partners in Health, which is an NGO working in Haiti, and trying to address the idea that HIV could not be treated in low-income settings. People were convinced that people wouldn't take the medication, they wouldn't be able to adhere to it the way that they needed to for it to be successful. And in reality, I think this was a form of systemic racism, thinking that people weren't able to engage in care and hence didn't deserve it. And so this photo was taken in Haiti, and you can see on the left is this young man, Joseph Jeune, at the time of his diagnosis with TB and HIV co-infection. Before treatment in February, March 2003. And on the right is the same man 6 months later after having been treated. So this was seen as really hope that this could work, hope proof that it can work, and that we should be doing more to enable it to happen. It led to the goal set by UNAIDS and the WHO of 3 by 5, treating 3 million people by 2005. It was an audacious goal at the time because there was very little treatment happening. At that time, fewer than 8% of people who needed treatment were getting it, and almost all of them were in low middle-income country settings. That was due to a number of things. The treatments not being available, the people not coming for diagnosis or engaging in care. And so there was a lot to do. But I'm happy to say that the gauntlet was taken up and things happened and treatment became available. And Canada played a role in that. Jean Chrétien helped with the move to encourage innovator drug companies to drop their patents on their drugs and allow them to be produced by generic manufacturers, predominantly in India. And today, the majority of people around the world are receiving generic treatments at a fraction of the cost of what they would cost in North America. So the same treatment that we would pay about $1,600, $2,000 a month, so $24,000 a year for in Canada, is now available for $50 a year in low-income settings. And so this is what's allowed success to happen. So moving on from 3 by 5, progressive goals were set, and now the UNAIDS goals are the 95-95-95 campaign, and that's to have 95% of people diagnosed and aware of their HIV. Of those, 95% on treatment, and of those, 95% virally suppressed, which is what happens when you take it every day. And so what was the status as of last year? Globally, we're at 86% aware of their diagnosis, 89% on treatment, and 93% virally suppressed. Not quite there, but this is miles from where we were. From a pediatrician's point of view, children are being left behind, unfortunately, and the gap between adults and children has persisted and unfortunately is increasing over time. So if you multiply those 95%, 95%, 95%, that'll tell you how many people are on treatment and suppressed. And so 77% of adults in 2020, end of 2023, were on treatment and suppressed versus 57% of children. Why is this? The major gap is in diagnosis. So we have good modeling of how many children should be living with HIV globally through awareness of HIV positivity rates and prenatal care HIV treatment of pregnant women, and birth rates across countries. And so the estimates suggest that we've only diagnosed about 2/3 of children who are living with HIV, and if we can't find them or we don't know who they are, then we can't treat them or get them to virally suppress. So this is the major gap in treatment, although the other two steps also have had their trials over time, but with newer, better formulations of drugs that are more potent, those parts are getting better. So in 2023, an estimated 1.4 million children and 1 million adolescents 15 to 19 were living with HIV. And you can see this number has been coming down each year. The difference between adults and children is that children become adults. So they leave our pool of numbers to be counted, and they join the adult pool to be counted. And so that's why we're not seeing this number go up over time. But the number who acquired HIV in 2023 was the lowest it's been since the 1980s, which is great. But you can see that the rate of decrease has fallen off over time. And the reason for that is that the number of women being diagnosed and on treatment has stagnated. So we've gotten stuck at about 80% of estimates of who should be diagnosed and treated. And so there's still work to do to find women living with HIV and be able to treat them prior to and during their pregnancies. So that's where we are globally. What about Canada? So since diagnoses started when diagnostics became available in the early 80s, about 91,000 people as of 2022 have been diagnosed with HIV in Canada. Of these, or in the last decade or so, we've settled down to about 1,800 new diagnoses per year in Canada, with about a 1.5 times higher rate of diagnoses amongst men than women. And if we look at who amongst those groups, over half of men being diagnosed with HIV are gay, bisexual, or other men who have sex with men, and about 1/3 are women living with are women. And the main risk factors for HIV infection in the women being diagnosed are those who inject drugs and those who are migrating to Canada from HIV endemic countries. And this in turn affects our pediatric numbers because these are the moms of our children that we're seeing in Canada. So about 5 years ago, we did a survey across Canada from our Canadian perinatal HIV surveillance program, or CPHSP. And the number of children living with HIV in Canada has remained relatively steady over time. We've been about 250 to 300 kids quite steadily. Each year, some move on to adult care, and each year we get new ones, mostly through immigration. And you can see that the distribution across the country is much like the population of Canada, with the biggest numbers in Ontario, followed by Quebec. But the prairies are overrepresented, and that's because we have a significant issue of HIV in our population of Indigenous Canadians, as well as amongst people who use drugs. So it is concentrated in those populations, and the numbers of new diagnoses of HIV continue to rise, unfortunately, in the prairie provinces, and requires greater attention. Amongst the children living with HIV in Canada in 2020, 2/3 of them were in the older age group of 13 to 20, and the numbers of younger kids with HIV were smaller. And so each year we lose a lot of our kids to adult care. We transition them to adult care. But each year they're replenished by as I said, mostly through migration, adoption, and very small numbers of new infections happening in Canada. Dr. Madhavi Prasad, one of our ID fellows, looked at the numbers to date in Canada with me through our CPHSP data last year. And basically what we saw was that thankfully there have been no pediatric deaths in pediatric care since 2005 amongst our cohort of youth. 70% of youth since 1990 had already transitioned from pediatric to adult care, and the remaining 30% were still in pediatric care. And half of the current cohort at that time were going to be moving into adult care in the next 5 years. And in the current pediatric cohort, higher proportions were residing in Western Canada, as I mentioned, and increasing numbers were born to Indigenous mothers and/or were born abroad. Okay, so that's the epi. What about treatment? So HIV therapy changed significantly starting in 1996. Prior to that time, we've been using one drug or two drug combinations or cycling of medications that were available, which were very few. But this really wasn't working because how HIV works is it replicates very rapidly and very sloppily. And so resistance mutations can happen very quickly when someone's on one or two drugs that are not potent and active. So in 1996, at the International AIDS Society meeting in Vancouver, research was announced of HAART, or highly active antiretroviral therapy, that was successful in treating HIV. So HAART is kind of an old term, and it was popularized at that time, and it was meant to mean 3 active drugs, usually from 2 different classes that they had not been treated with before or that their virus was not resistant to. But over time, we've kind of changed our terminology. So people don't really say HAART anymore. We talk about HAART combination antiretroviral therapy or just antiretroviral therapy because we wouldn't use anything that wasn't highly active anymore. So usually you can tell if someone's in the HIV field or not if they talk about HAART versus CART or ART. So as I said, these terms are all interchangeable, but in the past, this meant having to take typically many pills multiple times per day. So this was the classic image that you'd see in TV movies or in the media of people with a handful of pills, and usually one of those Casio watches that reminded you of your time to take it, because the PK of these earlier drugs was quite fragile, and that it really needed to be taken on time and with high adherence, or else you risked developing resistance. And the pediatric formulations of those ARVs in the old days were quite difficult to use. For young children, we were using these zidovudine and lamivudine solutions, which were pretty low concentration, 10 milligrams per ml. And young children were having to take upwards of 10, 15 mLs twice a day. So really difficult, especially for young children. And then the third drug, the anchor drug we call it, was mostly protease inhibitors like Kaletra or lopinavir ritonavir. And the problem with this is that they were very, very poorly tolerated. And Kaletra, or lopinavir ritonavir in particular, was extremely difficult to administer. The drug itself tastes quite bad, but to keep it in solution required having about 42% alcohol, 15% propylene glycol. To just keep it in solution so that it was stable. And when I was a fellow in training, we had a taste test. I don't know if this would be okay anymore, but they made us taste test all of the ARVs we're prescribing to kids. And I distinctly remember taking half of what should have been a pediatric, a typical baby dose or toddler dose of Kaletra, and it tasted like kerosene, like fire, and I had wicked reflux for the whole day. And so I'm really glad I did that, because it gave me the perspective of what we were expecting of these patients and of their parents in terms of getting their kids to take them. So for many years, we had crap drugs. And not only did they taste bad, but they had long-term side effects. And so we know that the NRTI family of drugs, in particular the D drugs, D4T or stavudine, and DDI or didanosine, and to a lesser extent zidovudine, could lead to what we call lipodystrophy and lipoatrophy. That's where people lose the fat, the subcutaneous fat in their face, in their arms and legs. And then with the protease inhibitors, we often had lipohypertrophy, where you would see the fat redistributed from the periphery to the center. And so you could see this fat pad on the shoulders and truncal obesity. And these things in turn were associated with metabolic abnormalities like dyslipidemia and increased cardiovascular risk. So these drugs were not good. And we were seeing these side effects not only in adults but also in children. It's a bit more difficult to appreciate in children because they have more fat when they're younger, but as they grew up, we started to see these lipodystrophy, lipoatrophy patterns, and as well the metabolic complications on their labs. But today is a far cry from where we were. And so in the initial days, we had three main categories or families of drugs: the NRTIs, like zidovudine, lamivudine, tenofovir; the NNRTIs, like efavirenz and nevirapine, which are early drugs, more recently rilpivirine and doravirine; and then the protease inhibitors like lopinavir or Kaletra that I was talking about, atazanavir, and the modern one, darunavir. But things have progressed. The integrase inhibitor and family, or INSTI, integrase strand transfer inhibitors, like raltegravir, the first one, which was twice a day, and now the other ones, alvategravir, dolutegravir, bictegravir, are really our workhorse. And the majority of people living with HIV are being treated with integrase inhibitors at this point. They're very well tolerated. They have very good pharmacokinetics, and they have become our mainstay. But for people who need other drugs, or in terms of moving forward, there are many other categories that have been developed. So we have fusion inhibitors, attachment inhibitors, NRTTIs, and capsid inhibitors like lenacapavir, and newer families and types of drugs are being developed all the time. And so really this has put us into the era of lots of options, although regrettably, the options for children are still quite limited, in particular for children under 6 years of age. But modern combination antiretroviral therapy no longer looks like this. It looks like this: one pill once a day. And these single pill regimens contain 2 or 3 or 4 drugs as a complete regimen, and they work better, not only because the medications are better than they were in the past, but also because people are able to take them better. Think about taking this handful of pills versus taking one pill once a day. And the smaller the pill, the better the adherence. And so I distinctly remember about 10 or 15 years ago, one of our patients who was on 2 pills once a day, and he really wanted to move. He asked if he should move to 1 pill once a day regimen because his mom had. And so I said, we can try it. You're eligible for it. And he switched to it. And he came back a couple months later and he said, I love it. And I said, oh, well, what's the difference? He said, it's just so much better. I'm like, well, what's the difference between 2 pills once a day and 1 pill once a day? And what he said was very revealing. He said, I just feel less sick. So taking less medication, even though the number of medications in that 1 pill is the same as what was in his 2 pills, in his mind made him feel better. And so I think we can't underestimate the impact of how people and patients feel about their medications on how it affects their adherence. So these 1 pill once a day combinations are available for adults and adolescents, but we also have much better options for children just in the last few years. So we have these ones, like dolutegravir, one of the integrase inhibitors, first became available as a tiny dispersible tablet that tastes good. So you swirl it in 5 or 10 mLs of water and the child can drink it. This was on its own initially, but now it's available as a 3-in-1 combination pill, the same as the adult pill called Triamec. This one's called Triamec PD, or pediatric dispersible. So they just take their number of pills for weight, disperse them in water, and take it, and it actually tastes good. So this has become one of our mainstays of treatment. The other thing is that adult tablets are now approved down to children over 25 kilos. And so that's around 8 to 10 years of age. And so, again, we're able to treat children with better combinations that they can take. And lastly, there's another pediatric formulation that's recently become available, which is basically about a half of an adult tablet that can be taken once a day for these children. So we have 2 good one pill once a day combination for younger children at this point, which is really amazing when we think about where we were 10, 15 years ago. The other big advance is injectable antiretroviral therapy. And so long-acting injectable antivirals are now available and licensed in Canada. And a couple of years ago, they were approved for not only adults, but also teenagers down to 12 years of age and 35 kilos of weight. And so they're rather large injections. So to be on them, it's one injection of each medication. So 2 injections every 2 months, intramuscular in the gluteal muscles, but people love it. And we've now transitioned about half of our teens here at CHEO onto them, and more are interested. And so this really takes away the need for daily adherence. It has always been a struggle for teenagers. And so this is a huge advance, and I only see it getting better from here. So from what I've told you, the ARVs work, they're easier to take, so everything's good, right? Not quite. So definitely things are better than the past, but multiple challenges remain, and they're mostly in the psychosocial domain. So social isolation and mental health remain persistent problems. HIV is a very stigmatized illness, and people don't talk about it with their friends or family, even within their family where multiple people have HIV. And so it's very socially isolating, and that in turn can lead to mental health distress. The social determinants of health and structural racism around HIV is also persistent. And these are struggles that affect many of our families affected by HIV in Canada, and the children included. And so it's hard to take your medications every day if you don't have food to take it with. And we see this in our clinic a lot, where food insecurity, housing insecurity, financial insecurity, immigration status unknown, all of these things are significant barriers to good adherence and engagement in care. And lastly, transition to adult care, which is a problem with all pediatric to adult conditions that require pediatric to adult transition. But in HIV, it seems to be a particular challenge. So what can we do? We know that for social isolation and in turn mental health, peer support is really essential. So we have teen groups here in our clinic, and most other clinics do as well, or teen groups in the community through AIDS service organizations. And we have several summer camps that allow kids to get together and get to know each other. And then once they know that they're not living alone with HIV, they feel better. We also can provide individual counseling, which not everybody's into peer support or talking to other people their own age. And so sometimes they need individual counseling. Around the social determinants of health and structural racism, we need more advocacy. We need to address racism in healthcare, and we need to empower Black, Indigenous, and other people of color to have just and safe care. We hear a lot of people saying that they hear healthcare workers saying negative things about HIV. They think that they don't hear, but they do. And so we need to address this. This is just, I tell people, HIV is just a virus. It's not a judgment. Nobody judges people who get influenza or like for COVID. I kind of was a little bit judgy for a while, but I think we all see that viruses are viruses, and they're not a judgment on who you are. And we really need to reinforce that in the way we talk about HIV. And lastly, transition to adult care requires more support. I'll talk a bit more about that. So what are the outcomes of children living with HIV in Canada? So we were able to answer this in a number of different studies through a cohort study called EPIC-4, the Early Pediatric Initiation Canada Child Cure Cohort Study that Dr. Lindy Sampson and I co-led with investigators across the country, and the study was housed out of Saint-Justin in Montreal. And we were able to enroll 228 children and youth with perinatally acquired HIV from across the country. This was the majority, like about 80 to 90% of the cohort at that time. And the study, its main purpose was to assess HIV reservoirs in children and whether starting very early, like at birth or in the first few months of life, impacted their reservoirs of HIV, which in turn impacted the potential for long-term outcomes. So in that study, we had longitudinal follow-up every 3 to 6 months at these 8 centers across the country. So one of our first questions was, what proportion of children in Canada are on treatment and virally suppressed, so part of that treatment cascade? So we did an earlier analysis of 211 children. Over 90% of them were on treatment, and of those, 90% had viral suppression. So that sounds good, right? Before 95, 95, 95, the goal was 90, 90, 90. So we were doing well at that point. But unfortunately, if you follow this was at entry into the study. And when we follow these children over time, we saw that after 36 months, 27% of children had had viral rebound, meaning their viral load went from undetectable to detectable. And after 60 months, their limited number with that much time, it went down to 58%. And the risk of viral rebound was lower in those initiating treatment at an older age, uh, with families who had not received social assistance in females. So if you look at the reverse, the risk of viral rebound was higher in those initiating treatment at a younger age, those whose families had received social assistance, and in males. And so this tells us that even in this semi-modern era, this was like 10 years ago, so the treatments were not quite as good at that point, but we were still struggling to keep kids on treatment and virally suppressed for many reasons. What else? We did do a review of how the kids were doing in their like non-HIV related spheres, and we saw that a quarter of children had some neurodevelopmental delay, which is not surprising in that perinatal HIV, especially if it happens in utero, can have an impact on the brain, like other viral infections, and so it can lead to neurodevelopmental challenges. And so, as I said, a quarter had some neurodevelopmental delay, most common being language delays. About a third had head imaging. That used to be our standard of care. We don't do it anymore unless it's clinically indicated. But about a third had head imaging, and of those, 70% had abnormalities, which meant, again, about a quarter overall had some neuroimaging abnormality, even though only 35% had imaging. And so this tells us that there's certainly a burden of neurologic injury. We also looked at learning, and so 16% had some form of learning disability, and 13% had failed at least one grade in school. Mental health diagnoses were also quite prevalent. About 30% had some diagnosed mental health disorder, including ADHD, depression, anxiety, or PTSD. And so these numbers are quite high, but it's important to note that these were passive diagnoses. And when we know that when people are systematically screened for these conditions, you'll often find undiagnosed conditions that you weren't aware of. And so these are probably not the true estimates, but the minimum estimate. And so it does provide advocacy power to say we should be doing mental health screening and neurodevelopmental screening in all children living with HIV, because their risk is quite high. And this in turn impacts their ability to transition into adult care. So transition to adult care, as I said, is a challenge for all chronic pediatric conditions that require ongoing follow-up into adulthood. And HIV has the added challenge of the stigma. What we hear from our families and patients is that there are significant differences between pediatric care, which is family-focused, developmentally appropriate, involves the parents in decision-making, and is often provided by a multidisciplinary team. And when they move to adult care, things are much different. It's very patient-focused. It's seen as a bit odd if you come with your mom to your adult appointment. And so it requires the autonomy of the patient and also good knowledge of their condition and how to manage it. Often the team size is the same, but they have far more patients. So here at CHEO, our clinic size is typically between 20 and 30 patients living with HIV, plus children exposed, uninfected, and sexual assault patients who start PEP. And at the general, where we transition most of our patients, they have 2,000 patients, and their staff size is quite similar to ours. And so you can see how they really can't address to the same level the needs of all their patients. And our patients, when they go over, feel the difference because the support is often at a much different level. I worked with one of our great pediatric residents at the time, Julia Hunter, on looking at transition outcomes for adolescents from our center over to the Ottawa Hospital. And this was done a couple of years ago. So we compared about 21 children who've been transitioned from CHEO to TOH, and we compared them to youth who entered HIV care directly. So likely these would be people who acquired HIV behaviorally, like through sexual exposure or bloodborne exposures, but were at the same age at the time of entering adult care. Basically, what we found was that our transition patients had less engagement in care in the first year after care entry, probably related to the differences in care and feeling reluctant to engage. That was in comparison to those who entered adult care directly. They had less time virally suppressed and lower self-reported treatment adherence, which again could relate to being on treatment for a long time. But interestingly, they had similar and high rates of mental health diagnoses in both groups, and in the adult care direct entry group, they had higher rates of STIs and addictions than in our transition patients. And so, to me, what this means is our patients need more support than the average patient in adult care, but so do the other youth living with HIV entering adult care. And part of why we wanted to do this review was we had heard about a number of our former patients dying or being admitted with AIDS illnesses on the adult side. Unfortunately, that didn't come out in this review because all of those patients had not transitioned to TOH, but to other care providers, or hadn't successfully transitioned at all. And so mortality should not be acceptable in this day and age with the HIV treatments that we have available. But I think it's easy to forget that a 21-year-old living with HIV has been living with HIV for 21 years. They don't look the same as the average adult patient living with HIV for 21 years, who's maybe 50, 60 years old, and is in a very different space and time in their life. And so, as I said, I think the take-home point is that youth moving into adult care need extra support, especially peer support, which often disappears from when they leave us and go into adult care where it's not organized in the same way. There are lots of issues that impact youth's ability to remain in HIV care: family issues, poverty, relationships, and being able to disclose to their partners, which is a very difficult thing to address. The stigma of not being able to discuss it openly with friends and family or anyone that you meet, due to the fear of how you'll be treated. Immigration issues, medications and maintaining coverage for medications, loss of support when they move from pediatric care where they've been coming for sometimes their whole life, into a new group of people who don't know them in the same way, as well as leaving their friends that they've gotten to know through our teen groups. But of all of these struggles, people living with HIV, both pediatric and adult, will all say the same thing, that the most difficult part about having HIV is stigma. And that's something that we need to work on. What works to reduce stigma? Knowledge. And so that's why I'm glad that you're all here today listening, because I want you to know modern information about HIV, and that in turn should reduce the stigma. Public awareness is very low about HIV, especially now in that it really doesn't have the same amount of publicity as it used to, and people think that HIV isn't a problem anymore. And so we need to educate health providers on how they can support patients, and we need to provide more peer support. Seeing people in the public sphere who are openly living with HIV is also really helpful. And so we have a lot of people nowadays that have come out and said that they're living with HIV, which is great. And here in Canada, we have a number of very strong youth advocates who themselves were perennially infected and want to speak out. And so these two young women, Maluba and Ashley, have done a lot of media and are often in the public sphere, especially in our research community. And it's really inspiring to see how they can touch other people just by putting their name out and being brave. So that's all about people living with HIV and children living with HIV. What about prevention? So some of us are of an older age and we remember what it was like in the 80s and 90s. So talking about don't share needles, no unsafe sex, the ABCs of HIV prevention, abstaining, be faithful, and condom use. But we've moved on a long way from there. Knowing your status has always been a really important aspect, because if you know that you have HIV, then you can prevent transmission to others. But we've moved on a long way from there. And in particular, I want to talk about a few things: treatment as prevention, U equals U, and PrEP. So I'm not sure how many of you have heard about U equals U, but I want you all to take that away as one of the main takeaway points for today. U equals U means undetectable equals untransmissible. So we know through excellent cohort data that someone living with HIV who is on treatment and has an undetectable viral load in their blood has zero risk of transmitting this sexually to another person. This was best informed by the initial partner study, which looked at gay male couples that were serodiscordant, where one was positive and the other was negative, and they followed them over years. And they showed that there were zero transmissions despite 76,000 reports of condomless anal sex. This translates to an estimated risk of less than one transmission in 435 years of condomless sex. This is very good evidence, and we can say scientifically that U equals U. This study was also replicated in heterosexual discordant couples with the same result. So we can say that this is true. And this was launched, this U equals U campaign was not launched by scientists, it was launched by the community as a stigma reduction intervention. So if people know that you can't get HIV from someone who's on treatment and undetectable, then they're going to be less scared. The flip side of this is that treatment is good not only for the patient, but good for prevention. And so we've modernized and expanded our treatment eligibility over time. We used to only treat people once their CD4 count dropped to a certain level, but now we recommend treatment for everybody immediately. And that's not only for their own health. We've shown that the people who start treatment immediately instead of waiting until their immune system is depleted do better. But we also know that it will prevent transmissions. And this treatment as prevention strategy, or TASP, was really pioneered in Canada by the BC Centre for Excellence in HIV and STBBIs. And they've been promoting this for many years, and it was taken up by the WHO. And that's what actually led to the 90-90-90 and 95-95-95 campaigns, was this idea of treating as prevention. And the numbers in BC have been well documented. HIV care and lab services are centralized in BC, so they have very good data. And they've basically shown that by making treatment available for everybody for free as soon as they're diagnosed, including people who are street involved and wouldn't normally be thought of as being able to take treatment effectively, has really reduced AIDS-related deaths, new HIV cases, and cases of AIDS-defining illnesses dramatically over time. The other big advance that has happened is PrEP, or pre-exposure prophylaxis. This is when an antiretroviral medication is taken in advance of HIV exposure to prevent infection. So the main one that has been available for years is oral daily TDF, or tenofovir, FTC, emtricitabine. So a combination pill. It's blue. Many people who've heard of PrEP think of it as the little blue pill. And it's been shown to be very effective in gay, bisexual, and other men who have sex with men, and transgender women. And studies in those groups have shown upwards of 92 to 99%, 95% protection overall, and 99% protection in those with high adherence who take it every day. There's also an on-demand version where maybe you don't want to take it every day because you're only exposed, say, on the weekends or once a month. And so the on-demand version is a 2-1-1 dosing, where you take 2 pills within 2 to 24 hours of your exposure, followed by 1 pill once a day for 2 more days. And that has also been shown to be highly effective. Unfortunately, this strategy has not worked so well for cisgender women. And multiple reasons have been postulated, but in low-income settings, they think it's related to stigma and women not wanting to be found to be taking oral PrEP, because then people will think certain things about them. And so the idea is that for cisgender women, PrEP hasn't worked in the past. But PrEP is very available, and this version is very available, and it's actually covered under OHIP Plus and Ontario Drug Benefit Program in Ontario. So all of our patients who would be at risk for HIV are eligible for free PrEP in Ontario. And so Sean Leonard, who is a pediatric resident in London, worked with a number of us and put out a guidance document. It's not an official CPS guidance document, but it's basically designed to be user-friendly in terms of enabling pediatricians who aren't HIV providers, or anyone, family doctors, nurse practitioners, anyone who's seeing youth at risk for HIV, can identify them, and it's adapted the adult PrEP guidelines for adolescents. And so I encourage you all to have a look at this and to think about how you might be able to improve PrEP uptake in teenagers. The next advance was long-acting cabotegravir or CAB-LA PrEP. So the same injections that we use for treatment, one of those two injections can now be used for PrEP. And there were two very seminal studies that came out a few years ago, HPTN 083 in men who have sex with men and transgender women, and 084 in cisgender women. And in these studies, they showed significant benefit: 66% fewer infections in MSM and TGW compared to oral PrEP. So compared to TDF-FTC, 66% fewer infections in MSM, and 89% fewer infections in cisgender women. So this was really a success, because we hadn't had as much success with women in the past, but long-acting injectable PrEP worked. So this was great, and this was actually just licensed for use in Canada in the last few months and is now covered by the Ontario Drug Benefit Program in Ontario. So again, this is a new option that I think would work very well for adolescents. But the real game changer came last summer at the AIDS 2024 conference, and the Purpose 1 trial of cisgender women in South Africa and a few other countries in Africa came out, and it compared oral daily TDF-FTC to oral daily TAF-FTC. TAF is a newer version of TDF with less side effects, and they compared to subcutaneous lenacapavir every 6 months, so 2 injections a year. And this study was a resounding success. It was 100% effective in preventing transmissions. And you can see that in the oral TAF-FTC and TDF-FTC groups, there was really no significant difference in transmission rates from the background incidence. So these didn't work again, or oral pills didn't work again for women, but lenacapavir was 100% effective. A few months later, the MSM transgender women study came out, and while not 100%, it was 89% more effective than oral PrEP. And so this is really a game changer. I was at the conference. This 10-minute abstract got a standing ovation, which I don't think I've ever seen at a conference before. A prolonged standing ovation. People were very excited about this, and it was named by Science as the scientific breakthrough of the year, because it has the potential to stop the HIV epidemic, particularly amongst the highest risk group, which is adolescent girls and young women who have the highest risk of HIV acquisition globally. And so this is really remarkable, and we're all looking forward to this being licensed and becoming available globally. Of course, the potential benefit of this is going to be negatively impacted by the cuts in the US to global programming for HIV, in particular HIV prevention. And that's one of the areas that the Trump administration has targeted as not wanting to support anymore. So real potential, but a lot of challenges ahead. So I'm running out of time, but I still have a few things that I want you to hear. So what's new in perinatal HIV? So HIV in pregnancy, we have had guidelines for years, and we know that if HIV is diagnosed before or during pregnancy, the mom starts treatment either pre-pregnancy or by the beginning of the second trimester. If she had IV AZT in labor, and baby got oral AZT for 6 weeks, and there was no breastfeeding, this would reduce the risk of transmission to less than 1%. One thing to mention, we used to call this PMTCT, prevention of mother-to-child transmission, but based on feedback from the community of feeling that language was not appropriate and really put a lot of blame on mothers, we've moved to instead use the terminology prevention of vertical transmission. So without treatment, we know that there's about a 30 to 40% risk of transmission, about 5 to 10% in utero transmission during the pregnancy, 10 to 15% at the time of delivery, and about 15% through breastfeeding, with the highest risk of transmission in the first month, when that high cellular component of colostrum is present, carrying a higher risk of HIV transmission through breast milk. But that's in the untreated scenario. When HIV is treated, we know that we get to less than 1%. And there have been really good cohort studies, including a large one from France that looked at over almost 5,500 pregnancies with 0 transmissions when all of these things were followed. In Canada, we have about 250 births per year to mothers living with HIV. And we still have between 1 and 5 transmissions per year. And these are almost entirely amongst women who did not receive treatment at all because they didn't know their status, they weren't able to, or we weren't able to engage them in care, or they started their treatment late and had an in utero transmission before the time of birth. But there are a lot of other changes that are worth mentioning. So cesarean section has always been recommended if the viral load is over 1,000, and it's still in practice, it's still recommended if we think that the viral load may be detectable, depending on mom's story. But if mom is virally suppressed, we no longer recommend IV AZT in labor. It's not been shown to be necessary if we know that she's remained on her treatment. And the baby can go down to 2 weeks of oral zidovudine prophylaxis from the original 6 weeks. And in Switzerland, they actually don't give any prophylaxis at all. And so this may be the way of the future. And the other big change that has rocked a lot of us is the move to support breastfeeding. And so in the past, there was a big dichotomy that women in high-income countries were recommended to formula feed their babies, and in low and middle-income countries, they were recommended to breastfeed, because studies of formula feeding in those places had actually shown you may prevent HIV transmission, but children were dying of other causes related to formula, not getting the maternal immunity through breast milk, and also in contaminated water leading to diarrheal disease and other infections. And so breastfeeding was thought to be a lower risk for that reason and lower cost. And as treatment rolled out for women, and women were recommended to start treatment for life, we saw that the transmission risk with a woman on treatment was very low. Recently, the PROMISE trial was published, which showed a very low rate of transmission when mom had an undetectable viral load. 2 infants in almost 2,400 patients. But other studies have also shown that although undetectable viral load is very protective, it's not 100% reduction in risk. And so we can't yet say that U equals U applies to breastfeeding, in that the risk magnitude is not at the same level as for sexual transmission. But with this said, we've recognized over time that by recommending formula feeding, we're denying both baby and mom of the benefits of breast milk and breastfeeding. And I don't need to explain the benefits of breastfeeding to this crowd, but for moms, there really are a number of benefits in terms of weight loss, cancer risk, depression, diabetes, hypertension, and so many of these conditions are more prevalent in women living with HIV, and so we've been denying them these benefits by not allowing them to breastfeed, or recommending against breastfeeding. And so there's been a big movement in the community, and globally, all of the national guidelines have been issued to say that women who are fully virologically suppressed can breastfeed under guidance. There's very little research on how to do this best. That's the problem. And so every country has put out their guidance. We here in Canada put out our guidance, but it's kind of made up, and every country's made it up slightly differently based on limited data. So in Canada, we recommend that it has to be exclusive breastfeeding, that the mom needs to have her viral load measured frequently, every month to 2 months, and that infants should take medications for prevention and be tested and followed closely through the breastfeeding period. And ideally would wean before 6 months, because we know that mixed feeding, either mixed with formula or cow's milk or with solid foods increases the risk of transmission in the untreated scenario. So you'll see this, that some of our patients are now breastfeeding. Still, the majority are choosing to formula feed because they want the zero risk option, but I think this will continue to change, and hopefully with research we'll have other safety net recommendations that may further reduce the risk of transmission. So we can say it's zero risk. I'll mention CHEU, so children HIV exposed uninfected. So as the pandemic has gone on, there are millions and millions of children now who've been exposed in utero to both antiretrovirals and HIV itself. It's estimated in 2023 there were over 16 million, and there's like 1 million or 2 million new ones every year. And in some countries with a high HIV historical prevalence, like 1 in 4 children are HIV exposed uninfected. In Canada, since 1990, we have about 6,000 who are born here and more who've migrated here. So are they okay? They may be uninfected, but they're not unaffected. And so multiple studies have been done that have shown a slightly increased risk of morbidity and mortality, morbidity in terms of hospitalizations, both for infections and non-infectious causes, poor growth and stunting, and speech and language delays, and other neurodevelopmental concerns. And this has been demonstrated in large cohort studies in low-income settings, but we also have data in high-income settings, including studies from Quebec, here in Ontario, and in BC that have shown the same results. And here at CHEO, where we, with sick kids, are doing a study called the KIND study that is specifically focusing on neurodevelopment and neuroanatomy, based on some animal models showing that specific drugs can lead to volumetric changes in brain regions, which has in turn neurocognitive effects that will be predicted from those regions. And so we're enrolling children ages 6 to 12 for MRI and neurocognitive testing to try and elucidate, are there specific drugs that are safest, and what exactly are the issues. So recruitment's ongoing. The last thing I wanted to talk about is cure. So I don't know if you've known, but there have been people who've been cured of HIV. The first one was the Berlin patient who came out publicly, and his name was Timothy Ray Brown. He was the first one. He's an American, but he was treated in Berlin. And all of the people who've been cured of HIV so far have all had a malignancy, often an HIV-related malignancy, and required a bone marrow transplant. And so smart people realized that they could look for a transplant donor who had HIV resistance. So there's this CCR5 receptor. So the HIV virus uses the CD4 receptor primarily to bind to cells, but then it uses a CCR5 receptor as the co-receptor, and that is required for it to enter the cell and establish infection. So people who have a mutated CCR5 receptor called delta 32, if they're homozygous for that mutation, they're actually resistant to HIV. And this mutation is more common in Western European populations, and it's thought to have been protective against the plague. And that's why more people in Europe have that mutation. And so for Timothy Ray Brown, they found a donor who matched him for his transplant, but also was homozygous for this delta 32 mutation. They zapped his bone marrow with ablative chemotherapy, and then gave him this new immune system that was resistant to HIV. And so in that way, he was cured of HIV. And he was followed for many years over time. He was very dedicated to science, underwent LPs and gut biopsies and lymph node biopsies and many things over time. Unfortunately, he passed away a few years ago from a recurrent malignancy, but he never got HIV again, or it didn't come back. So he was the first test case back in 2007. We're now up to 9 people who've been cured of HIV by bone marrow transplant. Almost all of them have had the same approach with a delta 32 homozygous mutated donor, but there have now been 2 people who've had bone marrow transplants without that genetic pattern. One from someone who had no mutation, and one was heterozygous for the mutation. And all of them are being followed closely over time. So obviously, BMT is not a solution for 40 million people living with HIV, but it does provide hope, and it gives scientists encouragement to keep trying. So maybe we can't do bone marrow transplant for everybody, but maybe we could develop gene therapy that would accomplish the same goal. So many advances have been made in this field because of that. But I think just knowing that some people have been cured of HIV provides a lot of hope. Last summer at the conference, with the standing ovation session, they also had a session where 3 of the cured people were on a panel. And so to be in the room with such rare scientifically valuable patients and have them speak about their experience and speak out to encourage other people was really inspiring. And lastly, what about children? So there have been children who've gotten bone marrow transplants in the hopes to cure them, but they all passed away, unfortunately, from their malignancy or from the transplant itself. There have been several cases of HIV remission. So this isn't where we did anything, but basically treatment was started very early. It limited the amount of HIV that established itself in the cellular reservoir for people, for these children. And then they came off treatment for various reasons, and their HIV either didn't come back at all. There's a French teenager reported in 2016, a boy in a South African study in 2019, and then the Mississippi baby was the original one. She came off treatment for almost 2 or 3 years before her virus came back. So it was thought that she probably just had like that one cell that eventually reactivated and started producing virus. But these cases are really inspiring. And this was the rationale why we developed the EPIC-4 study to follow our early treated patients. So we have many of these early treated patients, thanks to the high-risk prophylaxis that we start sometimes for babies exposed to HIV with no maternal treatment. And we think that there's value to early treatment because of these cases. And hopefully in the future, we'll have viable ways to cure children as well as adults. So I'm 2 minutes over, but these are the things that you learned about today. I really want you to take away that we have excellent new treatments that are easier to take, including injectable treatments that are approved for teenagers and hopefully soon for younger children, that we have amazing advances in prevention of HIV through treatment as prevention, U=U, and PrEP options, and that cure for HIV has been achieved and hopefully will be achievable for larger numbers of people in the future. Thank you very much.
Absolutely fantastic, Jason. Thank you. We won't punish you too much for going over. Just 2 or 3 minutes. And you've held the crowd. We've barely lost anyone. So so great work. There are a few comments in the chat. I don't know if you want to take a look at those and if you have a few minutes, see if you want to address any. Alternatively, if people have been waiting and want to raise their hands, we can make a few minutes maybe for some questions or comments.
Yeah. So I'll start with the first one about the USAID elimination. So this is a huge challenge. I've heard from many people in the field in Africa with my Clinton Foundation job that it's really rocked the scene, the landscape, and a lot of the like the medications are mostly still being funded through PEPFAR and USAID, but a lot of the support services around and the non-government clinic staff have been eliminated because of these cuts. The hope was always that PEPFAR could stop eventually and that countries would take over their own HIV responses and be able to self-fund them. But that was intended as a long-term plan, not as a abrupt stopping. And so there have been a tremendous amount of work trying to identify new sources of funding to support HIV response. But I really hope that things come back to normal in another few years, because the amount of progress that's been made, it would be horrible to see it go backwards, and I fear that it will, in the short term at least. Melissa, thanks. I totally agree that diagnosing people in the emergency room is extremely. Oh, I don't know what you mean. Maybe I'll ask you. I took it as one thing, but I think you maybe mean another thing.
No, I meant it meant that sometimes, people are like, oh, who's HIV? Oh, they have HIV. Oh, they have HIV. And so if there was a way to just be their undetectable viral load so that what the patient isn't hearing when they come into a clinical scenario where we should be able to say it's undetectable, there are your universal precautions and you can treat them like anyone who doesn't. I think it's that additional trauma that they're like, I'm in a healthcare setting where someone should know that, and it shouldn't be, hey, they have HIV, be careful, they have HIV. So it was just that part, like when we use the electronic record to indicate it, so that that is not one extra source. And I'm
100%
thinking,
agree.
yeah.
No, that's great. And thanks for making that point, because I think that's part of the thing about experience of stigma in healthcare is that people see healthcare providers being nervous, like, oh, they double gloved, why did they do that? Or, oh, they put something above my bed in the hospital. I find we don't have a lot of people with HIV and children with HIV admitted to hospital anymore, which is great, but it means that people aren't as familiar or as comfortable. But know that when they're on treatment and undetectable, they pose zero risk. Even if someone had a needle stick injury from someone who had an undetectable viral load, I don't think I would recommend prophylaxis at this point. So yeah, please take that into mind when we're dealing with our patients. And universal precautions are meant to be universal, not just for people with HIV, because you don't know who might have HIV and not know it. The last comment I see is about breastfeeding. Highlight change. Yeah, so we've put a lot of effort into changing how we approach infant feeding counseling, and also supporting women who may want to breastfeed. And so we ask for referrals very early so that we can go through what it would look like, make sure that everybody's on the same page, so that they know if they're eligible or not, and what it would look like. And it is a lot of work for both the families and for us in the clinic. But I think this is patient-focused care and family-focused care, and we need to do our best. And I think working together and everybody having the right information is the most important part, so that they're not getting different messages from different people. So that's why all of you, I wanted you to know about it, so that if you see someone in clinic, that you know that this is possible. Yes, in terms of making flags in EPIC, all of our clinic notes mention their viral load, so that it's easy to find, but I know that it's not easy to find notes all the time. Yeah.
Jason, a quick question for you. At the beginning of it's more general. At the beginning of the talk, you mentioned, the size of the pill and the number of pills being an indicator to the patient about how sick they are and impacting adherence. I'd also read quite a while back about the number on the pill, them feeling that there's a relationship between the size of the unit and the strength. I was curious when you were talking about the injectable, do you have any sense of getting an injectable, I think you said every 6 months versus taking a daily pill, like the trade-off between they might feel an injectable intervention is a greater sign of illness, but yet the decreased frequency, like any sense of the trade-off there between
Yeah. I mean, on the treatment side, I think the youth that we've started and the adults that I've talked to, like the parents of our patients who started injectables, they all say the same thing, just the liberation from not having to take a pill every day and not be reminded, oh, I have HIV. I better take my pill. Oh, I have an HIV. Instead of that being a daily occurrence, it's like once every 2 months. That is really the difference in terms of why people prefer. It is quite a pain. It's like a 3 ml injection in each butt cheek every 2 months. But all of our teenagers who started it were like, it hurts, but I'm never going back to pills if I can. And so I think it's just the convenience and the psychological benefit. For the prevention, like the every 6 month prevention, I think that will be like really essential in terms of just, it is a very small injection, and it can be delivered in so many ways. Subcutaneous injections don't need to be provided by a healthcare provider. I think the potential for that to succeed is huge, and I can't wait for it to become available. The generic production of lenacapavir, Gilead, the innovator that developed it, has already released the patent and is working with 6 different generic companies, mostly in India, to develop production so that it can be rolled out. That was before the Trump administration came in, so not sure how that will be affected. But yeah, it's very expensive in Canada, or it's very expensive in the US, where it is already licensed for treatment. Not for prevention, or I think it might be licensed for prevention there now, but yeah, it's like hugely expensive here, but it's going to be available, I think, for something around $40 per year. Yeah.
There's a few
So I
more
don't want to keep people away from their day.
La-
I really appreciate everybody.
Done do
tuning
one
in.
more question and we'll call it, Jason.
Sure. Which one?
In the chat. You pick.
Do we know about the approach perinatally in France and Switzerland concerning very low transmission prevalence? So in France, they've always done the same as us here in Canada in terms of their approach. So the Swiss are very liberal. They're the ones who started the U=U approach of no condoms after you're undetectable, and they have been promoting breastfeeding for a long time, and they give no prophylaxis to babies. They're very liberal. So they're a small population, though, so it takes time to get enough data to reassure us all that that's the way to do it. But yeah, keep your eye in that space. Vive la Suisse, c'est ça.
Well,
Okay.
thank you, Jason. We're not in a room together, so we can't do a round of applause, but for those remaining, maybe they can find their clapping button. There's 1, there's 2, there's 3. Thank you, Jason. Well done.
Okay. Thank you so much. Have a great day.